So moving forward, with these symptomatic patients, how do I choose the frontline therapies? So just as a brief timeline, we are in a golden age for therapies in myelofibrosis and MPNs. I mentioned the activation of the JAK-STAT pathway as kind of an analogy of a light switch. And we have all these therapies collectively known as JAK inhibitors that can turn off this light switch. There are four main JAK inhibitors nowadays that are approved in the past decade or so, mainly Ruxolitinib, Fedratinib, Pacritinib, and Momelotinib that can do exactly that. Now, how they work, they inhibit a couple different receptors on the patient's malignant cells that are really important, including JAK1, JAK2, and ACVR1. JAK1 and JAK2, as they're signaled downstream into the DNA, they use the JAK-STAT pathway that I mentioned is the most important part of MPNs. But for myeloproliferative neoplasms, inhibiting this one on the right side, the JAK2, is the most important. You may hear about JAK1 inhibitors in other autoimmune conditions such as psoriasis and lupus. And there's a third pathway using a receptor called ACVR1 that we've learned is actually very helpful for a couple of the myelofibrosis patients. So we've learned that for some of these medications that are newer, called pacritinib and momelotinib, inhibiting ACVR1 actually has a side benefit, and then it corrects anemia in certain conditions, particularly myelofibrosis. So all four of these JAK inhibitors have different levels of inhibiting JAK1, JAK2, ACVR1, amongst other receptors. And that leads to some of the niche nuances about how these JAK inhibitors can be helpful for the upfront setting in myelofibrosis. There are many different paradigms to think about how to start a therapy, but here are just a couple. There are many different risk stratification systems that I'm not going to be talking about, but some of these risk stratification systems include looking at patients' blood counts, symptoms, presence of leukemia cells called blasts, and presence of adverse mutations and chromosomal issues. We can risk stratify generally into lower risk and higher risk patients. And therefore, we can think about how we treat the patients. Now, one specific point that warrants calling out is that these JAK inhibitors are very, very good at shrinking patients' spleens and reducing their symptoms. But soberingly, they don't change the big picture. They don't really delay the progression to acute myeloid leukemia, and that would have happened regardless of if we started a JAK inhibitor or not. And that leads me to that first point. For asymptomatic patients, I'm very comfortable to not start any therapy and just observe them, because the majority of my decision making for patients is largely driven by patients' quality of life and goals. So, moving forward, there are other paradigms that other disease experts, such as Dr. Ferry at the Mayo Clinic, have relayed. But at a high level, I just provided the summary on the right side. Most patients with symptomatic splenomegaly with a large spleen, up front, they're going to get the first one, ruxolitinib. And if the ruxolitinib is not working, typically we switch to another one called fedratinib, but with the novel JAK inhibitors in the past 2 years with very specific niche nuances, very helpful in the thrombocytopenic patients, pacritinib, and very helpful in the anemic patients is momelotinib. And that leads us to a very personalized, very complicated regimen of a lot of JAK inhibitors that we can reach for in our bag of tricks. So the clinical takeaways is that the therapies are targeted mostly to alleviate symptoms in myelofibrosis, including shrinking the spleen, amongst the other B symptoms of fevers and night sweats. Each JAK inhibitor has nuanced indications, particularly with thrombocytopenic patients and anemic patients. But as I mentioned soberingly, that there's no current therapy that prevents progression to acute leukemia.